Good afternoon, everyone, and welcome to a new decade of Grand Rounds here in Dundee. I'm never quite sure how long into the year you can still say Happy New Year, but it's the first opportunity to see many of you, so Happy New Year to you. My name's Tom Forden, and I'm the Chair and Organiser of Grand Rounds, and this session today kicks off our semester of activities. We have a wide range of different talks over the next 3 months before the Easter break, including external speakers visiting from afar, local talent, many different departments involved across the whole of NHS Tayside and the university, and visiting speakers who've come all the way from the dental school across town. Grand Rounds is for everyone. I was very keen when I set this up about 5 years ago that it's not just about medicine, it's not just about doctors, it's about everybody who's involved in healthcare across Tayside. If you are in a blue top today, which there's plenty of you are, as an AHP or a nurse, then please do pass on the emails if you get them to your colleagues. It would be nice to have more input from our nursing colleagues, AHPs, etc. And if you want to give a talk, then please let me know. There are some gaps in the rota, mainly due to a bit of jiggling around and the lull that happens over Christmas. So if you're sat there with a burning idea that you want to stand up here and talk for 40 minutes about a research idea, or you've got a service development, or just something you think is interesting that for a general audience, then please let me know by email, Twitter, Facebook, whatever. Let me know what you'd like. The dates I put in the email, and they're basically sort of February, March time. We'll continue into the summer. And there's every date you could possibly hope for from May, June and July, but we do take a small break over in August. Now, I was accosted in the corridor, as I frequently am accosted in corridors. I can't walk across the length of this hospital without being stopped by 3 or 4 people. And Claire Stubbings stopped me in December and said, "Can we have a Grand Round slot?" "Oh, of course you can." And then she said, "Every month," which is even better still. And Claire's working with the Faculty Development Office, which is just upstairs and opposite the Deanery. And they're there to provide what has been highlighted by numerous NES visits as a high-quality exemplar service of training the trainers. And they want to come to Grand Rounds to tell you all, trainers, what they're doing in their service development to help our trainees and our students. And I said in the email that it's not just about medical students. The whole of NHS Tayside is full of nursing students, dental students, radiography students, AHP students, you name it. And it's important that we provide good quality training for all of them. I remember as a medical student 25 years ago, sitting in lots and lots of clinics and standing on lots and lots of ward rounds, being fairly bored to tears, being ignored and feeling like a complete spare part. And not a clinic goes by without a student coming into my clinics. I try very hard to make them not spare parts, but I think we're all so busy. We've got so many competing interests, not least the patient sat in front of us as our primary focus. And so these students can be ignored. I don't think anybody sets out to ignore their student, but it does happen. And we've got a team at the front here who are going to come and speak to us about how to improve the experience of our students when they're on observational or shadowing attachments. So Jordan's going to start off, and then it's Kirsty, and then Claire, and then Alana. Yes, excellent. Last thing, I apologise for the lack of 2 screens. This projector here has had enough and has just clapped out, so it's not working. So if you do want to move across to that side because you can't see from this end, then do so now. Perth are missing because I can't project the image. It's not that projector projects to Perth. It's not that clever. It's just that without 2 projectors, I can't stream it across to Perth. But this is being recorded. My nonsense is recorded forever. It goes onto YouTube. We have 150 subscribers. You could be the 151st, and you can watch these later. There is a QR code on the screen. This enables them to find out that you are here. They will email you a certificate of attendance. If you've got an iPhone, just point your standard camera at this. You don't need a QR reader. The phone is clever enough to work out what's going on. Point it at that, it sends you to the right web page. So enough of me, and on to Jordan. Spontaneous round of applause for Jordan, everyone.
Has everyone managed to get the QR code to work okay? Okay, good start, excellent. So yeah, if you fill that in, we'll be able to give you a certificate of attendance with a CPD point attached to it as well, so that's quite exciting. I also said that I would provide tea and coffee, and we have done that too. My name's Jordan Napier. I work in the medical school as staff development lead, so as Tom said, part of my role is to support the staff working at HPCT side who are teaching medical students and doctors in training to kind of develop in their educator role. So we've got 4 speakers here today, so I'm just going to introduce things and then pass it on to Kirsty. But we wanted to kind of think about, over the past couple of months doing the curriculum review in the Dundee MBCHB, we've been thinking about how do we enhance the learning opportunities actually within the clinical environment, because that's the bit maybe we find we have least control over, and it's a little bit more difficult because the students are not the main focus of the work that's going on in the ward. So as this is a medical education talk, I've written some very specific learning outcomes. So we're going to think about active observation and how that can be used to enhance opportunities. Kirsty, Claire and Alana are going to talk about different examples from their own context. So that'll give you a different idea of how this could be used in different environments. We've got theatre environment, we've got kind of hospital palliative care, we've got general practice, and I would like you to leave encouraging you to think about how you might use some active observation guidance in your own setting. So as we're going through it, you could be thinking, when was the last time that maybe either a student came and asked if they could observe me or I asked the student just to watch what I'm doing? So just keep that in the back of your mind. So I used to work in the medical education team in Tayside, going through all the student evaluations of their clinical attachments. And during that time, there was a lot of data to read and a lot of the students telling stories about their experiences on attachment. And the feeling you got a lot of time was when they had a really good experience, it's because they felt like they had a specific role to do. They knew what their job was in that attachment and they just got on with it and felt like part of the team. When the feedback wasn't so good from the students, it was when they felt like they really weren't sure what their role was. As Tom said, they felt like a bit of a spare part. They were kind of floating about in the background of the ward, not really with a clear purpose. They were maybe often asked to shadow members of staff, but not really understanding what the objective of that shadowing was in the first place. We asked quite a small group of students, 37 students, these questions here using Mentimeter, just a small ad for Mentimeter as well, a very good website that you can do voting on. And as you can see, like some students were saying it's pretty clear what's expected of them. I thought it was interesting that it was up a little bit more, the students saying that it can be a little bit overwhelming, and this will be different at different stages and for different learners as well, as you can imagine. I wanted to just kind of touch upon the fact that healthcare's changed in recent years, and therefore we probably have to change how we're teaching healthcare as well. So there's been shifts in care continuity, there's probably more handover, there's different members of the team involved in teaching now, and like Tom said, maybe grand rounds is seen as a very medical thing for medics, but actually that's not how health education works. It's a team sport. There's an increased number of learners in our clinical environments these days. I'm sure some of you have noticed that, and I think that's probably just going to keep ramping up a wee bit. Patient empowerment, patients know more, know where to go to get information more, and there's different healthcare practitioners turning up in these environments as well, and we need to think about how we kind of utilise their expertise for teaching too. The other thing that's in the background is realistic medicine, which is something that in Dundee we're really keen to get integrated into the curriculum, thinking about students right from word go, understanding what personalised approach to care means and what shared decision making means. So really we want to be able to integrate these things into our teaching too. Now, we had to put a little bit of educational theory in because you are getting a CPD point for it. So one thing to think about in terms of how students are learning in the clinical environment is this idea of experiential learning. So the learner does have responsible for their own learning. And actually, they should be doing practical things and not just learning about the theory. They need to apply it in order to solidify it and for that to make sense. And really then we should be kind of giving them that experience to scaffold and keep giving them more complicated things to do so that they're always developing. This slide is definitely a last minute slide, and you can see because it's quite messy. But I also just wanted to show another theory about education. You don't have to read that all, it's very wordy, but about kind of the cognitive apprenticeship model. And you can see the first one there is that when a student's been introduced to something, you want them to observe to see how it's done so they can conceptualise it. So actually there's a real kind of value in observing. And although students often, it may make them feel like a spare part, if we do it right and give them the right guidance, it can be a really valuable learning opportunity, which is what the whole talk is about today. Also just wanted to kind of, as background information, show this diagram, which I'm sure many of you have seen a lot recently, the new GMC outcomes for graduates. The top bit there about students developing as professionals, and it's about the values and behaviours. And we think that some of this active observation stuff really helps us help the students appreciate these things in the clinical environment as well. So things like the ethics of healthcare, dealing with complexity and uncertainty, leadership and team working. I made this on my new iPad with my new Apple Pencil, so I hope you enjoy my little doodle. But I was thinking about learning in clinical environments at its best. What it is, it's a brilliant community of practice. It's a whole group of people learning together. That's my little community there. There's only 3 of them, but I know in reality there's a lot more than that. Learners can get familiar with the context of kind of healthcare, how the different systems work or maybe don't work so well sometimes. What they'll be doing is developing their professional identity and start to understand what it means to be a doctor or a physiotherapist or a nurse. And also they're learning from and with patients as well, which is so much more valuable for the students as well sometimes than just kind of having purely being taught by the staff member. However, at its worst, learning in the clinical environment can be really unclear. It makes them feel like spare parts sometimes. The complexity of it all can be overwhelming. There's so much going on that a learner at kind of the early stages of their healthcare education career can just feel a bit lost in that. So that was just to highlight that. And I just wanted to specifically mention the paper that I've referenced here. Claire Morris wrote this paper about teaching and learning through active observation, and this is just a quote from her paper that, again, I've drawn because I want to get the most out of my Apple Pencil that I got from Santa. So observation at its best is an active, purposeful task that stimulates deep learning. But at worst, it's a passive process that leads to either heightened anxiety or total shutdown in the learner. And I'm sure I've done observations in clinical environments as a non-clinician knowing nothing about it, and if I don't have a specific focus, I would feel completely overwhelmed by being in that environment. So I'm probably quite a good person to put myself in the shoes of maybe a second-year student that's going along to a ward for the first time for their ward-based teaching. So our proposal is that giving a bit of guidance about what you're asking someone to observe can be really powerful and be quite an easy way to make the most of these opportunities. So Claire Morris in her paper talks about priming learners by giving them observation tasks, so being quite specific about what you're asking them to do. You're wanting them to learn to look purposely at things rather just kind of taking the whole thing in or honing in on one specific objective, and Kirsty's got quite a good example of that from labour ward. And also allowing learners to start to organise their observations. And learning to observe well is a fundamental skill of healthcare professionals in itself, so actually getting that bit of teaching in too. So at this stage, I'm going to pass on to Dr. Kirsty Brown, who is one of our teaching fellows and is also an ST in obstetrics and gynaecology.
Thanks, Jordan. So I'm starting my part of the talk with a stolen slide from Jordan, but I think this is quite a nice quote and sums it up quite nicely. I liken this to watching a film for the first time. So when we all watch a film, we are caught up in the main characters and the main dialogue, and all the smaller parts sort of fade into the background, and some may notice it and some may not. If you watch that film again the second time round, your eyes are a bit more open. You kind of know the main characters, so you're a bit more open to the smaller parts in the background. That's essentially situational awareness. As healthcare professionals, our aim on a daily basis is to try and see our environment like we're watching that film for the second time. We want to be open and try and pick up those smaller parts and be aware of our whole environment. When we get our students coming onto labour wards, they are really enthusiastic and so excited to see the main character as such, the baby being born. But actually there's so much other things in the background in this really rich learning environment that can often be missed as part of that. So it could be something as simple as, how does a midwife support a woman in labour? What phrases do they use? What tactics do they use in what can sometimes be a really challenging situation? How do they discuss pain relief options with a woman that is completely exhausted and in lots of pain? Likewise, how do they discuss risk? How do they consent them for procedures in labour? What are the challenges that we face in that situation? And these can all be missed opportunities in the clinical environment. By focusing on these little bits and giving the students these little tasks to do, it's essentially heightening their situational awareness. So when they're next in that environment, they'll be more open and they can see the other parts that are going on around them. Now, situational awareness is important in any specialty, but this slide is really showing how crucial it is in acute specialties like obstetrics. This data is taken from an initiative called Each Baby Counts. This is a national improvement project run by our college, which is set out to investigate why babies die or are injured during labour, and their aim is to try and reduce those numbers by half. And what this is essentially showing, when they've looked at human factors contributions, situational awareness and communication between the teams is contributing to almost half of these cases. So this is such an important skill that we need to be teaching. So in Obs Gynae, our fourth years come to us for a 4-week block, and they spend time in all these areas. It can be quite exhaustive, it can be quite overwhelming being in all these new environments. In particular, students feel quite daunted coming to labour ward and theatre. These are quite different environments than what they're used to. So I'm just going to focus a little bit on that in my next couple of slides. So think about theatre, for instance. This is a unique learning environment and it can foster a powerful learning experience. However, students often feel uncomfortable in theatre, and looking at some of the literature around this topic, the same themes are coming through. And anecdotally, it's things that I hear from the students that are coming through our department. They can feel intimidated, excluded, not really sure what they need to get out of this, not feeling prepared for theatre, and feeling quite burdensome to the team that they're coming into. So then I thought about, why do students feel like that, and what can we do to overcome this? I think coming into any new environment is really difficult. Particularly in theatre, it's often teams that have worked together for quite a long time, so it can be quite daunting. For us as clinicians, it can sometimes be very difficult to teach in the traditional sense in theatre, particularly when we're time pressured. So we're often under this pressure to finish the list on time. There's often knocks on the door, phone calls. When are you finishing the list? Do you need more staff? Are you going to run late? Do we need to cancel a patient? That can be quite stressful. Also, you might come across a case that you didn't think was going to be challenging, and then it is. And it takes you away from giving the time to the student. In this situation, active observation can really come into its own. And you can think about the other aspects in theatre that, again, are not traditionally taught. And actually, the WHO recommend that these concepts are introduced at an early level, at the undergraduate level. Things like patient safety concepts, so getting them to look a bit more closely at what are we discussing at the safety brief, having a look at the WHO checklist, why is that important? Also the opportunity for non-technical skills training, looking at the communication, looking at the team working, and it can, in particular, if we have come across a technically challenging case, instead of focusing on the actual case, which is what everyone wants to do, but it can be quite difficult to learn in that environment, look at the rest of the situation, what's going on and what can we get out of that. So here is a couple of examples. I've got one for theatre, one for labour ward, which I've kind of touched upon in the last couple of slides, of what does an active observation guide look like in different settings. So here's theatre, and as I said, I've just touched upon this. First of all, we ask them, we talk about what we want them to observe. Now, it might be what they want to observe, because we're encouraging them to come to us with ideas as well. And then the second part of the guide is where you need to be specific. So we're asking them to observe the preoperative meeting, but what about the preoperative meeting? So we want them to look at the steps that are taken to ensure patient safety. So that could be the safety brief, the WHO checklist. What specifically is discussed at these times, and why is that important? And why might it differ from case to case? And then we want to make sure that they understand the purpose for this. So in this case, we want to introduce them to patient safety concepts, surgical safety, and non-technical skills. In labour ward, so you've got a student come into a room watching a labouring woman. As I said earlier, they all just can't wait to see that baby being born. But babies, unfortunately, do not arrive when you want them to. So what else can they look for in that situation? As I said previously, you might want them to look at what the midwife's doing to support that woman in labour. What are the barriers that they face? What are the challenges? And how does the midwife approach it? And then you can get them to look at how does the midwife multitask everything that she's doing? How does she make sure that mum's okay, baby's okay? What are the different monitoring tools that they use? And what's the purpose of this? Introducing them to person-centred care in the context of a labour ward that they haven't been exposed to before. And then also looking at the monitoring of both mum and baby. So that was all I was going to say, and I'll pass on now to Claire.
Hi everyone, I'm Claire Stubbings. I'm a GP, I'm a clinical teacher, and I work with Jordan in faculty development. So I'm just going to have a little chat about how we are considering looking at things in general practice from the active observation standpoint. So I'm just a girl winging her way through medical education, medicine and life. We've seen this is how students can feel too, and I think when you have a less experienced facilitator or tutor, there can be an element of feeling like you're winging it through a particular teaching session. And not knowing what students don't know and being in an overwhelming clinical environment and not knowing what you're meant to be doing with it can probably be leading to some sort of suboptimal educational experience and possibly quite poor feedback for the session that's been participated in. This is another quote from the Morris paper, which I'm not going to read out, but I think if you just look at the last part of that, there are different expectations at different points, and I think that's something that's quite important to bear in mind when we're thinking about active observation. We'll expect different things from different students at different stages as they progress their way through medical school. So we traditionally have had students come out probably for their first clinical experience in medical school into general practice, where they would come in and they would sit for an afternoon probably in the back of a surgery with a GP. They may have some experience of going around some of the admin, being introduced to some of the members of the practice team. So what would active observation add to this particular experience, given that these are students who don't have a huge amount of clinical and probably communication skills experience? As previously mentioned, active listening and active observation allows the student to control their own learning. But the general practice environment has its own set of unique challenges. We're delivering this type of teaching across multiple sites with a diverse range of facilitators who have a varying degree of experience. An active observation guide could provide guidance for both the facilitator and the student as to the intended learning points for the period of observation that they're participating in. Now, on a wider sort of thought, that has inherent value for the institution itself. It may enable a degree of standardisation of the educational experience, and that would allow a bit of quality control to come into things as well. Very junior students participating in their first clinical experience have very limited, if any, clinical knowledge. So we could ask them to focus on generic components of the environment and the consultation to help them engage with the experience and to maintain their focus. I know that I did once fall asleep in an endocrine clinic. It was really dull. So thinking about some points that we could look at in a general practice environment. So the environment itself, we could ask the students to think about what do patients see when they first come into the practice, how are they welcomed, what strikes you about the way that the consultation room is laid out, really generic basic things, but it gives them something to focus on when they come into practice. The practice team, who have they encountered and what were their roles, and again we could set some learning objectives. As a GP tutor, I can see students coming right through to third year that I've taught from first year who still don't know what a district nurse does. They still don't know what a health visitor does. And there's perhaps missed opportunities when we have them in the practice environment to lay the groundwork of that sort of knowledge. Then you can drill it down into the consultation itself. And again, bearing in mind these are students who will have little to no clinical knowledge, just general things about communication. How does the GP establish rapport? Does this differ between patients? Someone you've known for 20 years versus someone that you've seen for the first time. And what do you notice about the questions that the doctor's asking and how are they asked? Difficult situations are always challenging for anyone, but they're even more challenging when you've got a student in the back of the room, but that does not mean to say that they are not a valuable learning opportunity. For both parties, actually, it can be quite useful to debrief and chat things through. And that's it for me. I'll hand over to Alana.
Thank you very much, Claire. I'm Alana Browncare. I'm one of the registrars with the Palliative Care team, and I'm also fortunate enough this year to be one of the medical education fellows working with this team. And I'm going to talk about a fairly different environment from the others. So the Hospital Palliative Care team is a liaison team based in Ninewells. We're a really small clinical team. There's 2 consultants, 3 clinical nurse specialists, 1 registrar and 2 specialty doctors. And on an average day, we probably have 3 clinical staff members. Throughout the academic year, every week we have students with us for half a day. So it's quite a time commitment for the team. And a few years ago we would have had 3 students at a time, and we now have 5, and that number is probably going to increase. And what that means is that for our small team, we're often having 1 clinician with 2 students following them. So what we've been running at the moment, the current format, is a session. So the morning they come in, they have 30 minutes introduction, and they then go out and shadow one of our team for about an hour and 30 minutes. That's usually 1 or 2 patient encounters, and then they will then come back for a half-hour debrief, which is facilitated by a member of the team. It's quite unusual within the UK to have students routinely rotating through hospital palliative care. Most students experience palliative care education in the hospice setting, and so what we're offering in Dundee is fantastic, but we need to find a way to make that sustainable in the long term as our student numbers rise. And we know that junior doctors are coming out and they're feeling unprepared to deliver palliative care, and they want this undergraduate experience, and we want to give it to them. But it's difficult in the clinical environment to undertake challenging consultations with students in the room, and difficult with multiple students, and it's difficult to feel that need of put occupy there, to keep the students engaged with what you're doing in this context. There's also, talking to our team members, been a feeling of uncertainty about what to cover during the sessions, because we have a huge variability in the types of clinical encounter that we're having. And one of the other challenges that we face is that as a ward liaison service, we're going into other wards, other clinical environments that we don't have overall control of, and often you don't know exactly what you're going into. I think specific challenges for the students within, the time they spend with our team. We're dealing with 4th years. These are students who are used to a much higher level of autonomy. When they do their acute care block, they're independently clerking patients. They're used to being independent, and suddenly they're coming in and we're asking them just to watch and to shadow. And that can feel quite disempowering and frustrating for them, and can lead to non-engagement. We know it's a potentially emotionally difficult topic for them, which can lead to anxiety before the session and during it, this feeling that they might be asked to do something that they don't feel comfortable with, although we don't ask them to. And as I've alluded to earlier, there's this huge variability in the types of consultations. So in a given day, we might just be seeing a patient to talk about a simple pain review, or it could be someone who's actively dying, or it could be complex discharge planning. So trying to prep a student for all of those different situations is quite tricky. And I'd just like to sort of highlight, I've said here it's inappropriate for students to lead the consultations. I don't know, I think people might have different views on that. I think the view that we take is that these are students we've never met before. We get them for 2 hours, and we don't have a chance to really see what their skill set is in advance. Maybe they would manage to lead the consultation, but is it appropriate in the context of this patient's journey to have that uncertainty? So we have them in an observational role. So For those of you who've done real research, I apologise for this. This is a very small sample that we started before Christmas of 5 students, and we asked them, after they'd done the session with us, was it useful to observe the consultation? And thankfully, they said yes. And was it clear what they were actually expected to be observing? Less clear, really, from them. I know it's tiny numbers. And then finally, the key question, would you like more guidance on observation? And more of them said yes, but we would like to increase the number of the sample size over the coming months. But we did then ask them, how could we improve the session? What could we be doing? And interestingly, one of the students independently had came up with this quote that they actually would like specific things to be looking for in the consultation, which was quite heartening, because that's what we think is important, and obviously the students do too. So I'm just going to talk through 2 of the kind of observation guides that we're looking at with the hospital palliative care team. So obviously with palliative care, communication is so important, and this first one is about actually focusing really on the clinician and how are they communicating to the patient. What are the phrases that they use? Write those down so that we can discuss them at the end. What's their non-verbal communication? Are they sitting? Are they standing? Are they kneeling at the patient's bedside? And then getting them to think about the communication skills training that they've had. What are the techniques that are being used or not being used? Why is the person not chunking and checking or signposting? Has that been a conscious thought that that's not appropriate in this clinical setting? And then obviously the purpose at the end is to try and get them to start to compare and contrast communication styles in different consultations, think about why that might be different. And the second one I've got, so this is quite different, is getting the student to think about why the liaison palliative care team have been asked to see this patient. We know that all the wards in the hospital are providing generalist palliative care. What was it in particular about this patient that meant the specialist team was invited to contribute? And if they were the FY1, which is only 18 months away from most of them, what would they write on the referral form? And what we'd like to do is give them the referral form so they can see what information we've been given. Was it good enough? Could there have been more? And actually, are there other things the ward team could have done before referring to our team? So asking them to sort of critically appraise and evaluate the referral process as part of the observation. So this wouldn't necessarily be a within consultation observation, but the students are with us the whole time on the ward. So there's a 10-minute period where I'm standing writing up my notes of the consultation, where the students potentially stood next to me like a lemon, not getting very much. And this is the type of thing that we could be getting them to spend their time on. And there's a few other areas that we're also looking to develop. I think it'd be really lovely to look at observation guides about how we interact with the ward team and the MDT. How do we communicate as a liaison team what our opinion is for the patient? Do we do that verbally with the junior doctors? Is it written in the notes? How do the ward team interact with that information? Observing the atmosphere and environment around a dying patient and the effect that has on a wider ward team would be a lovely opportunity for the students, because we know that they're often closed out of the dying patient and don't get that experience. So that's something else we're looking at. And then finally, of thinking about communication by patients and by families, asking them to focus on that aspect. So I'm going to pass over to Jordan. Thank you very much.
I'm getting memories of being at assembly in school, how we did our little kind of rotation of seating patterns there. We thought it was important also just to be mindful that there's disadvantages or potential challenges with this approach as well. Potentially, students that are disengaged might still be disengaged, even if we give them very specific tasks to do, and we have to be mindful of that. But you're hoping that you might, by giving someone a really specific thing to do, kind of pull them out a little bit. There's definitely a requirement to be flexible with this. It's not one size fits all. You're not going to say this is what we need you to focus on, because every learner is going to be different. They're going to have different things they want to develop, and what you ask medical student to observe an HP doing might be different from what you would ask the specific physio student to do, for example. There's maybe a bit of staff development around that, but we exist and we're happy to support you in that. Our experience so far has been going along to teams to discuss this concept, brainstorming over a coffee, and then we've come up with the bones of something that could be taken forward and be used. So I'll even provide the coffee. Potential admin burden if you're wanting to get things printed out, I suppose, but actually the concept is the important part rather than the written thing. It's about kind of making sure that we are given the opportunities for these observations and kind of just making it plain to the students what these opportunities are when they arise. Whole team buy-in definitely helps with this, because we want that to be part of what the student's getting, is learning about the different roles and the team communication and systems. But also just to say that obviously active participation is always encouraged if possible. We're just talking about the situations where observation is the only way of doing it. And I know that there's a real struggle for outpatient clinic teaching at the moment. There's not enough time for us to have a really nice consultation and then have time in between to chat it through and debrief with the student. It's just kind of one in, one out, and therefore at least maybe something like this could optimise the time that the student's there. We've got this kind of cheat sheet to help you think about active observation. So if you've just slept for the past half an hour, you'll get this. If you would like, any of you that have actually managed to get onto the QR code and sign in, we'll send you these slides and a copy of this, so you can take that away and mull it over. And just because I'm wanting to be proper today, I'm going to put the objectives back up again. So we've spoken quite a bit about our reasoning behind this. My colleagues have given some really nice examples from different clinical settings. And hopefully you've kind of had the chance to think about when you might just be asking someone to watch what you're doing, and actually what is it specifically you want them to look out for, and what is the objective that's attached to that. And this is my call to arms. So next time you ask a student to observe you or ask just watch, just consider specifically what is it? What is the purpose of that? And if you're interested in chatting this through, even informally, over the phone, you can't phone my email address, but that's my email address, get in touch and we can help you out with that. And I also just wanted to put that reference slide there because I know that Tom puts these videos on YouTube. The other thing I was going to do is pop the QR code slide back up again for anyone that wanted to sign in. I will put that back up. But we're also happy to take any questions that anyone has about this. Thank you.
So the first thing, Claire, is you shouldn't be too worried about falling asleep in an endocrine clinic. I think that's pretty standard. I once had a house officer fall asleep on my ward round, which I think is more a reflection on me than it is on them. But so I win on that one. So has anyone got any questions or any comments if they want to add to the discussion? I think one of the things that I've found difficult over the how many years I've been here, teaching here, 15 years, was knowing what level of student is sat in front of me, or stood in front of me in a ward round, and we've tried to address that in the medical school at least by having different coloured lanyards, which got me into trouble for having lanyards, although I've lost my lanyard now and have one of these things. But that really helps knowing there's a first year sat with you rather than a fifth year, because they're very, very different learning objectives and needs, and I think that's very useful. I do have nursing students and HP students come sit with me in clinic, and that can be a bit of a challenge to know at what stage they're at and what they're after. And I think that preloading the beginning of the discussion with what do you after. The other thing I've found useful is telling them they don't have to be there the whole time. I think there's this expectation that students have to be there for the whole 3 hours of my clinic, and actually that's a lot. It's an awful lot of listening to me. So you can probably get a huge amount out of the first couple of patients, and then go away and spend the time doing something more, thinking about it, reflecting on it, doing other things more useful. So I very much tell them, come and go as you please. If you had enough after an hour, then please clear off, but get something out of it. Any comments, got questions? Anything they want to say? Okay, I think the team are going to hang around for another 10 minutes if you want to come and speak to them, or you want to get some of the paperwork, or you want to engage with them. You can phone her email address. 2020. Yep. Okay. Next week, visiting speaker from all the way across town in the dental school, bringing oral health medicine back into general medicine, how we can try to re-engage with our dental school colleagues and Max Fax as well, and the importance of the oral signs of systemic disease and vice versa. So I'd just like to thank the team at the front who have come to assembly and done their talk, and I'll see you all next week. Thanks very much.